Hello to all of the audiences. In this next occasion, we are from SGD number B1, would like to present our student project entitled Multiple Myeloma. But before we are going through the presentation, we would like to introduce you our group of member of SGD number B1 which shown in the slides. For the next speakers, the time is yours.
Okay, so hello everyone, my name is Farida Husniadiba with the last digit of student number 102. So I'm gonna explain about the background of multiple myeloma. So cancer is a disease that caused by the abnormal cell division that can metastasize throughout the body. Cancer that originates from the blood cells, or called blood cancer, grows within the bone marrow, and one of the most common blood cancer is multiple myeloma, which accounts 10% of hematologic malignancy. Multiple myeloma commonly occurs in elderly group from 60 to 70, and more possibility in Black African American than white people, and the cases are high in United States. According to the Global Cancer Observatory, the new case recorded in Indonesia is 3,159 in 2020, which is almost 0.8% of all cancers in those countries. And then multiple myeloma is a blood cancers that result from the proliferations of the plasma cell that characterized by the sudden increase of monoclonal immunoglobulin. The clinical manifestations are hypercalcemia and the renal dysfunctions, anemia, and the lytic lesions on the bone. The patients suffer from this multiple myeloma can be diagnosed by the clinical features or the blood or urine electrophoresis, and the management may be complex, involving the systemic treatment. Therefore, more about this multiple myeloma will be discussed in this paper. Okay, for the problem formulations, we have what is multiple myeloma, what is the etiology of multiple myeloma, what is the pathophysiology, what are the risk factors, how to diagnose, what is the differential diagnosis, and last is what is the treatment and management. For the objectives, we have general objectives to learn more about multiple myeloma in general and how do we manage patients with multiple myeloma. For the specific objectives is first to know about the definition of multiple myeloma, to understand the etiology, to gain knowledge about the pathophysiology, to seek deeper about the risk factors, to learn more about the how to diagnose, to know about the differential diagnosis, and to have knowledge about how to treat and manage patients with multiple myeloma. The benefit is to gain and explore our knowledge about multiple myeloma and how it applies clinically on patients by understanding the definitions, etiology, pathophysiology, risk factor, diagnosis, differential diagnosis, treatment, and management. I guess that's all from me. Thank you.
My name is Arya Arnas. Utility number of student ID is 002. I will explain about the definition of multiple myeloma. Multiple myeloma, or MM, is a clonal proliferative disorder that forms in a type of white blood cell called a plasma cell, characterized by the abnormal increase of monoclonal immunoglobulins. The excess production of this plasma cell can lead to specific end organ damage. Most commonly seen, at least one of the following clinical manifestations are present: hypercalcemia, renal dysfunction, anemia, or bone pain accompanied by lytic lesion. That's all from me. Thank you.
Okay, thank you. My name is Gede Pramaditya Wahisaputra, and the last three digits of my student numbers are 045. In this occasion, I would like to present the epidemiology of multiple myeloma. So, based on the statistic by the Global Cancer Observatory, it is known that globally there are 160,000 incidents of multiple myeloma occurring, which only represents 0.9% out of all cancer cases reported. It is most likely to occur in older people in the age above 70 years old, with male patients slightly having the higher risk of having multiple myeloma than female. Approximately 90,000 cases of male patients and 70,000 cases of female patients. Multiple myeloma is reported to have an increased incidence in Black people, which is African American especially, about 2 times incidence than white people. So the next presentation will be presented by my friend. Thank you.
Hello everyone, my name is Denise Sandira with my last digit number 160 and I will explain about the etiology of multiple myeloma. So the cause of multiple myeloma is still a mystery and in some cases multiple myeloma or MM is linked to high radiation like nuclear chemicals, obesity, alcohol consumption, environmental pollution like Agent Orange, organic solvent and also virus. In a previously conducted study by Abu Ghosh, MM is actually frequently associated with the frequent change and translocation in the promoter genes, particularly in chromosome 14. And it is also said and believed as multiple myeloma is a non-genetic condition and not inherited and quite unusual happen to more than one person in a family, although it could still happen. And according to data collected by the Globocon, about 0.9% of diagnosed cancer in 2018 were cases of multiple myeloma. The number successfully placed multiple myeloma as the 14th most common neoplasm in the world, with men dominating the charts. The next one will be presented by my friend. Thank you.
Hello everyone, my name is Asi Kirana with real life student number 087, and now I would like to explain about the pathophysiology of multiple myeloma. The development of multiple myeloma or MM is usually preceded by a premalignant plasma cell condition called monoclonal gammopathy of undetermined significance or MGUS. There is a 1% annual chance that MGUS will develop into MM. In certain patients with smoldering multiple myeloma or SMM, an intermediate disease that is already malignant, the likelihood of progressing to MM is around 10% annually. The myeloma cells are derived from B lymphocytes from post-germinal centers that undergo errors in the physiological process of somatic hypermutation or SHM and class switch recombination or CSR. When these processes go wrong, the immunoglobulin H locus or 14q32 undergoes chromosomal translocation that causes dysregulation or elevated expression of oncogenes that are located close to the potent immunoglobulin enhancers, including cyclin D. This results in the production of monoclonal immunoglobulins, which cause MGUS due to their uncontrolled proliferation. Additional genetic changes acting as second hits that accelerate the development from MGUS to MM may include deletion on 17p13, mutation in the RAS gene, activation of nuclear factor kappa B, and overexpression of BCL2, allowing cells to evade apoptosis. Multiple myeloma, as the final stage of development, causes damage to an organ known as CRAB, C-R-A-B. C is for hypercalcemia, R is for renal failure, A is for anemia, and B is for bone pain, which is a common tetrad in MM diagnosis. Okay, I think that's all from me. Thank you.
Hello, my name is Nyoman Gede Wiragunatri Paramarta. The street digit number is 180, and I'm going to continue to explain the pathophysiology of multiple myeloma. In multiple myeloma, increase of the class activity is the result of complex interaction between malignant plasma cells, the bone microenvironment, and other components of the skeletal system. Malignant plasma cells in multiple myeloma secrete many growth factors, including interleukin-6, tumor necrosis factor alpha, and macrophage inflammatory protein 1 alpha. These factors stimulate osteoclast activation and increase bone resorption. Additionally, there are changes in the RANL or OPG signaling pathway with increased RANL production stimulating osteoclast activation and decreased OPG inhibiting osteoclast activity. So that's all from me. Thank you.
I'm Gustia Krisania Maputri with last three digits of my student number R143 will continue with the risk factor of multiple myeloma. So the multiple myeloma risk factors can be categorized as three main category, which is first, patient characteristics as an individual, which is related to age, therapeutic intensification, performance index, patient response to therapy, and comorbidities. Second, tumor load or burden, which related to the elevation of beta-2 microglobulin cell level, thrombocytopenia, lactate dehydrogenase levels, and anemia. The third one is tumor intrinsic cellular characteristics, which related to leukemic presentation, high index of plasma cell proliferation, extramolecular disease, and molecular and cytogenetic abnormalities. The translocation of chromosome 4 and 14, 14 and 20, 14 and 16, elongation of chromosome 1q, and deletion of chromosome 17p are the high risk factors of multiple myeloma. Patients with renal failure, hypoalbuminemia, and poor treatment have a poor prognosis. And to estimate the overall survival rate or prognosis of multiple myeloma patients, the assessment that can be done are the Dury-Salmon staging or DSS and Revised International Staging System or RISS. That's all from me. Thank you.
Okay, thank you for the time. My name is Yuda with three last digit of my student numbers is 069. In this next occasion, I would like to tell you about the diagnosis of multiple myeloma. Understanding multiple myeloma involves recognizing it as one stage in a range of plasma cells disorder. This idea is echoed in the National Comprehensive Cancer Network or NCCN guidelines. The NCCN guidelines suggest these tests for the diagnosis. The first one is complete blood count or CBC to assess various blood cell levels including platelets. The second one is testing for blood urea nitrogen, creatinine, electrolytes, albumin, and calcium levels. The third one is evaluation of serum LDH and beta-2 microglobulin levels. The next one is assessment of serum immunoglobulins through serum protein electrophoresis or SPEP and serum immunofixation electrophoresis or SIVE. The next one is analysis of 24-hour proteinuria along with urine electrophoresis or UPEP and urine immunofixation electrophoresis or UIFE. The next one is conducting a serum real light chain or FLC assay. The next one is performance of either whole body low dose CT or PET CT scan. The next one is bone marrow sample extraction to aspiration and biopsy, including immunohistochemistry, flow cytometry, and cytogenic analysis. And for the last one is plasma cell examination use FISH or fluorescence in situ hybridization for specific genetic abnormalities such as deletions or translocation. Beside of those NCCN guidelines for diagnosing multiple myeloma, there are also three distinct biomarkers play a crucial role in diagnosis. The first one is a high percentage of abnormal plasma cell in the bone marrow. The second one is an abnormal ratio of certain proteins in the blood, such as serum free light chain ratio more than 100 with an involved FLC levels more than 100 mg per liter. And the last one is the identification of multiple abnormal areas on MRI scans. Okay, that's all from me. For the next speakers, the time is yours.
Hello, I'm Mario with student number 123. Right now I'll be explaining about clinical and laboratory findings that can manifest in each stages of multiple myeloma diseases. Starting off with MGUS, we can find a protein serum concentration of less than 3 grams per deciliter, free light chain ratio of less than 0.26 or more than 1.65, 10% of clonal plasma cells, and the absence of myeloma dividing events. We continue to the second one, the slow or smoldering symptom stage in multiple myeloma, which calls smolder multiple myeloma. It can be discovered in the stage that monoclonal protein level is greater than 3 grams per deciliter, clonal marrow plasmacytosis is around 10% and 60%, and there is still no signs of myeloma dividing events. Myeloma dividing events can be discovered in multiple myeloma of the last stage. What are myeloma dividing events? It consists of Krebs symptoms, which stands for hypercalcemia, renal failure, anemia, and bone lesions, and slim biomarkers, which stand for greater than 60% plasma cells in bone marrow, elevated free light chain ratio, and bone lesions finding on MRI. That's it from me.
Hello everyone, my name is Rafadiar Rafajri with my last three digit of my serial number is 244. 2.6 Differential diagnosis of multiple myeloma. So the first one is monoclonal gammopathy of undetermined significance. The characteristic is the first one, it has serum monoclonal protein less than 3 gram per deciliter, and then clonal bone marrow plasma cell less than 10%, and then it has no end organ damage. The second one is smoldering asymptomatic multiple myeloma. Uh, the characteristic for this one is it has monoclonal protein is greater than or equal to 3 gram per deciliter. The clonal bone marrow plasma cells is between 10 to 59%, and then it has no end organ damage. And then the third one, symptomatic multiple myeloma. The first one, the characteristic of this symptomatic multiple myeloma is the presence of at least one myeloma defining condition, and then it has greater than or equal to 3 gram per deciliter M protein on blood findings, and it has greater than or equal to 60% plasma cells on bone marrow biopsy. And then the fourth one, Waldenstrom macroglobulinemia. The characteristic for this one is it has immunoglobulin M paraprotein, and then it has hypercellular bone marrow with plasma cell, lymphocyte, and lymphoplasmacytic on bone marrow examination. And then the fifth one, light chain amyloidosis. The characteristic for this one is it has immunoglobulin light chain on blood findings, and then it has less than 10% plasma cells and congruent staining on bone marrow biopsy or fat PET biopsy. And then the last one is plasmacytoma. This one is a rare condition with tumor positive for plasma cells and it has negative for plasma cells neoplasm on bone marrow examination. Maybe that's all from me. Thank you. Continued by my partner.
Hello, my name is Jennifer Pramesti with the last 3 digits number 208. So now I'm going to tell about the management and also the treatment for multiple myeloma. So multiple myeloma is the second most prevalent blood malignancy. Proteasome inhibitors and immunomodulatory medicines are two independent groups of medication used to treat multiple myeloma. Each of them operates via various mechanisms and has distinct side effects. Proteasome inhibitors works by suppressing the enzyme that breaks down protein in cells but is overactive in multiple myeloma cells, which causes an accumulation of misfolded proteins, resulting in cellular stress and cell death. Bortezomib is the most often used proteasome inhibitor in multiple myeloma. Bortezomib is typically administered as a brief intravenous infusions on days 1, 4, 8, and 11 of a 3-week cycle with a 72-hour interval between infusion to allow for recovery of proteasome inhibitor in normal cells. The most common adverse effects include fatigue and weakness, gastrointestinal disorders such as nausea and vomiting, diarrhea, and also constipation and thrombocytopenia. Immunomodulatory medicines have become more important in the treatment of multiple myeloma. This medication, which include thalidomide, lenalidomide, and also pomalidomide, have exhibited enhanced anti-cancer activity and improved the natural history of the disease. Thalidomide was the first immunomodulatory medicines used for multiple myeloma, and it has been utilized in a variety of treatment scenarios, including first-line therapy, stem cell transplant maintenance, and relapse cases. However, thalidomide has been linked to dose-limiting toxicities such as teratogenicity, thromboembolic events, dermatitis, constipation, and neurotoxicity. That's all from me. Thank you.
Hello, my name is Komal Sri Bungasdani with the last 3 digits of student number is 241. I will continue to explain the treatment and management of multiple myeloma. The other treatment is autologous stem cell transplantation or ASCT. Patients who fulfill the criteria for transplantation first undergo induction therapy with a triplet drug regimen, generally bortezomib, lenalidomide, and dexamethasone. They are administered for 3 to 4 cycles, then followed by autologous stem cell transplantation. Meanwhile, patients with advanced age, comorbidities, and other conditions that do not meet the standard for transplantation will generally receive treatment with 3 combination drug regimen. The first-line treatment includes daratumumab combined with lenalidomide and dexamethasone for 8 to 12 cycles. The dose may be reduced or adjusted based on the patient's condition due to the high risk of side effect in this patient population. Monoclonal antibodies are one of the therapeutic options in multiple myeloma that have developed significantly. Daratumumab is one of them. Daratumumab often emerges as an effective option used in relapsed or refractory multiple myeloma patients. Multiple myeloma is a disease characterized by multiple phases of remission and early relapse. Therefore, patients with multiple myeloma will eventually relapse. The introduction of therapeutic options such as proteasome inhibitor, immunomodulator, and monoclonal antibody has undoubtedly been a positive development for patients with multiple myeloma. On the other hand, these drugs, typically combined with medium to high dose of dexamethasone, lead to decreased immunity. As a result, patients with multiple myeloma who take the drugs for an extended period are at risk of infection. If untreated, This infection can become a significantly cause of morbidity and mortality. Therefore, efforts to provide prophylaxis should also receive attention to prevent a worsening prognosis. The choice of treatment depends on several factors, such as the extent of the disease, the patient's overall health, and the response to previous treatment. Essentially, there is no specific medication for multiple myeloma. In addition to medications, doctor, other healthcare professionals, and family or patient's companions play a crucial role in providing supportive care. That's all for me. Thank you.
Thank you. My name is Gede Panamaditya Wahyu Saputra, and the last three digits of my student number is 045. In this occasion, I would like to present the conclusions of the student project. So, the clonal proliferative disease known as myeloma or multiple myeloma develops in the plasma cells, a type of white blood cells that are distinguished by an abnormal increase in monoclonal immunoglobulins. By producing antibodies, healthy plasma cells assist in the fight against infections. Antibodies seek out and combat pathogens. But instead of producing beneficial antibodies, cancer cells produce malfunctioning proteins. This results in multiple myeloma complications, causes damage to end organs known as CRAP, which are hypercalcemia, renal failure, anemia, and bone pain, which is a common tetrad in multiple myeloma diagnosis. The presence of any CRAP criteria or one of the three additional biomarkers justifies both diagnosis and the initiation of therapy. Multiple myeloma has multiple risk factors that cover various human physiologic and clinical aspects. Some of them are older age, tumor load, and then gene mutation, and also patients with renal failure, hypoalbuminemia, and poor treatment response have a poor prognosis. Multiple myeloma can be treated by the use of corticosteroids, anthracyclines, proteasome inhibitor, immunomodulatory medicines, histone deacetylase inhibitors, and monoclonal antibodies. That's all from me. Thank you.
Okay, that's all from our student project presentation of SGD number B1. We would like to apologize if there are any mistakes on this video. Thank you for watching.